My name is Ben Yates. I'm a consultant podiatric surgeon and I work here at the BMI Ridgeway Hospital and also in the orthopaedic department at the Great Western Hospital in Swindon. So today I'm going to be talking to you about common causes of foot pain, how to assess some of those causes of pain and when to consider referral. So there are many different causes of foot pain, and sometimes we can group those into systemic diseases such as diabetes, rheumatoid arthritis. It may be due to structural causes such as somebody who's got flat feet, high arch foot, or structural differences or abnormalities which may be occurring above the foot and ankle but have an obvious effect on somebody when they're walking, so such as hip arthritis. There are neurovascular conditions, there are infective conditions, obviously trauma can cause a lot of pathology within the foot and ankle, and dermatological conditions as well. So, what should we assess? Well, obviously you've only got a short period of time in order to look at somebody with a foot and ankle problem as part of general practice. And the first thing to do is to ask the patient to stand barefoot. In this situation, you can have a global look at their foot and ankle position, and also deformities become quite obvious. So for example, if someone's got very flat feet, high arch feet, if they've got bunions, hammer toes, all of these things become much more obvious when somebody stands. It's worthwhile looking for skin lesions on the underneath of the foot or on the top of the foot, which may be calluses or corns, which are obviously an indication of abnormal pressure in one particular area. We should look at the pulses and feel the pulses and the overall temperature of the foot. You can look at capillary refill time in terms of looking at the circulation. Muscle strength, one of the easiest ways to look at muscle strength is just to ask the person when they're sitting on a couch to try and push your hands together, push your hands away, pull your hands up towards them and push your hands away from you in a downward direction. And in that way you can test the inversion strength, the eversion strength, dorsiflexion strength and plantarflexion strength. You might want to look at specific range of movements of joints and potentially test the reflexes if you think there might be a neurological condition, and then you're going to hone in on the site of the symptoms. So we haven't got time to talk about all of foot and ankle pathology, so really what we're going to look at is some common conditions. These common conditions are as listed there, so we're going to talk about bunions, we're going to talk about hallux rigidus, arthritis to the big toe joint, metatarsalgia, plantar fasciitis and Achilles tendinopathy. And these are some of the commonest conditions that I see and treat. When we think about bunions, it's important to think about not only the degree of deformity that's present, so how big a bunion has the patient got, but also how much pain, how much disability is that bunion causing the patient. We need to think about how much arthritis may be present within the big toe joint, and in particular we need to think about other foot deformities. Bunions, as they progress, will often cause deformity of the lesser toes, particularly the second, sometimes third toe, but also it can be a source of pain in the ball of the foot and also further up in the arch, because generally the bigger a bunion becomes, the flatter the arch becomes. So when we look at these pictures here, you can see that these are varying degrees of bunion deformity, and a lot of them are really quite severe. But actually that doesn't mean to say that the really severe ones cause the most pain, as there are a number of studies which have shown that the size of a bunion doesn't actually dictate how painful it is. Sometimes I see patients who've got big bunions and they come to see me because really their main cause of pain is what's happening to the second or third toe or possibly into the ball of the foot. So for example, neuromas are more common in people who've got bunions. What conservative treatment options are there for bunions? Well, obviously wearing wide, sensible footwear, low-heeled is going to help, preferably with a soft upper material. Orthotics, splints, and possibly an injection into the joint. If you look on the internet, you can see that there are a multitude of different treatment options which are out there, and these are just an example of some that you can see. There are commissioning guidelines which have been published on the internet, which will help to determine treatment algorithms and moving forward in terms of surgical treatment. However, there is no effective conservative care that's been demonstrated in the literature, and therefore often patients who've got symptomatic painful bunions are likely to require surgery. If we're thinking about a surgical procedure for somebody who's got hallux valgus, well, again, we need to assess the degree of deformity, we need to assess the presence of arthritis and post-operative issues, such as would their patient be able to cope with a post-operative regime associated with certain bunion procedures. The majority of surgical correction for hallux valgus involves an osteotomy and additional treatments of the soft tissues, so tightening tissues which have maybe become loose and stretched, and also releasing structures which may be overly tight. One of the commonest surgical procedures that's performed for hallux valgus these days is a scarf osteotomy with an additional Aiken osteotomy, which is an osteotomy to the proximal phalanx. If the patient has got severe arthritis, then it may well be more appropriate to perform a first MTP fusion. And if they've got a very severe deformity, often with hypermobility in the middle part of the foot, then a Lapidus procedure, which is a fusion of the first tarsometatarsal joint, is a more appropriate procedure to perform. There's been a lot of debate in the literature about open techniques versus minimally invasive surgery techniques. And it's important to understand that effectively the surgical principles are the same. People who often ask about minimally invasive surgery believe that this is a quick fix and they'll be back on their feet and back doing normal activities much faster than if they've had open surgery. And actually that's not the case, because the thing that determines the longevity of the post-operative regime primarily is bone healing. And that's the same whether you perform surgery via a minimally invasive surgical technique or an open technique. Minimally invasive surgery is also only really more appropriate for minor bunion deformities. However, if the surgery is performed accurately and appropriately, even in really very severe conditions, you can get a very good outcome, as you can see here in a before and after clinical photo. And this patient required a Lapidus procedure due to the severity of the bunion deformity, and they've also had their second hammer toe corrected, as you can see there. Arthritis in the big toe joint is associated with pain, restricted range of movement, often a dorsal bony bump. Sometimes there's deformity developing of the interphalangeal joint and overuse of the interphalangeal joint. When you look on an X-ray, you can often see obvious features of arthritis, as you can see on this X-ray image here. We've got osteophytes which are developing, we've got narrowing of the joint space, we've got what's termed subchondral sclerosis. What treatment options are available for hallux rigidus? Well, standard treatments would include, again, footwear advice. You'd want to wear a shoe which without an excessive heel, because that's going to put too much pressure on the big toe joint. Again, a material of soft upper, leather usually, or canvas on the for the upper, so that it's not going to press against the bony prominences. The use of insoles can also be helpful, but can often be difficult to accommodate in a lot of shoes, because the insole will raise the foot inside the shoe, which can then put pressure on those dorsal bony bumps. Injection treatment is a common treatment for arthritis of the big toe joint, and it's one of the commonest injections I perform. However, multiple injections are not recommended. And the reason for this is that in the long term this is likely to cause an acceleration of the arthritis in the joint, and also it can mean that bone healing can be delayed and often complicated in the presence of multiple cortisone injections in the joint. So if the patient does end up having surgery, for example, the risk of non-union is much higher in somebody who's had multiple cortisone injections than somebody who hasn't. Ultimately, if those above measures fail, then realistically we should be considering surgery. Now, from a surgical point of view, there are different options based on the level of arthritis. And one of the commonest features which I'm advised when patients is that they've been told by healthcare professionals that there's nothing that can be done until the arthritis is at its end stage. And actually that's just not true. There's a lot of evidence that will tell us that we can do much better surgery in patients who've had mild to moderate arthritis and potentially prevent them from requiring end-stage arthritis surgery. Cheilectomy is to remove the bony bumps, and this can be effective if the patient has mild to moderate arthritis, particularly associated with bony bumps. A long-term study which followed patients for over 10 years demonstrated a 90% satisfaction rate at 10 years with this particular procedure in patients who met that criteria. Decompression osteotomy may be used if the metatarsal is overly long or in a dorsiflex position, and that can take pressure out of the joint and preserve the lifespan of the joint. A cartilage resurfacing implant is showing promising early results, and this otherwise known as a Cartiva implant, and you can see that on this image here in the central part of the slide, can effectively, was dubbed the contact lens for the joint, because effectively it's made of contact lens material and it allows movement to the joint and reduces the pressure against the arthritic elements of the joint. And ultimately, if the surgery if the arthritis is very severe, then a fusion procedure is likely to be the most beneficial. Metatarsalgia is effectively a common blanket term used for pain in the ball of the foot. And there are a number of causes of metatarsalgia, being Morton's neuroma, predislocation or instability of the metatarsophalangeal joint, particularly the second, stress fracture, arthritis, and Freiberg's fracture. We haven't got time to talk about all of those particular conditions, so we're just going to concentrate on a Morton's neuroma. This is a common problem. As I mentioned earlier, it's more common in people who've got toe deformities, particularly bunions. It's also more common in females, so we assume that footwear is likely to play a role. How do we diagnose a Morton's neuroma? Well, if you look here on the slide, you can see there that effectively what we're doing is that we're compressing the forefoot. So this is a squeeze test or Mulder's click, and this is most effectively combined with retrograde pressure from the thumb squashing the soft tissues against those metatarsal heads, as you can see in that slide there. And then finally, you can try and provide direct compression between the bases of the toes at the MTPJ level. It's always sensible to perform these tests on an asymptomatic space before you then move to the symptomatic space, so that the patient can understand what you're trying to achieve, and therefore hopefully you'll get a more positive response when you come to the symptomatic space. Treatment for Morton's neuromas really consists of wide-fitting footwear, low heels, insoles which can be helpful, injections. Again, I'm not a keen fan of multiple injections. 1, maximum 2 injections is usually all that's recommended, and if that fails, then realistically the next step would be surgery. And surgery involves excision of the inflamed, thickened nerve. Plantar fasciitis. Many people will have plantar fasciitis throughout their life. 10 to 20% of the population are likely to experience it at some point in their time. There are many risk factors. We know that it tends to be more common in sedentary people, particularly if their job involves prolonged standing, and also those of the athletic population as well. Clinical examination is really quite straightforward, and this really is a clinical diagnosis. So, as you can see there on the picture, what we're going to do here is we're going to dorsiflex the foot, dorsiflex the toes, and then we're going to look to palpate the most painful area. This is usually where the plantar fascia originates, which is in the sole, on the central part on the underneath of the foot, effectively here. Now, you need to push quite hard in this area because we've got a thick fat pad. That fat pad can be up to 1.5 centimetres, so you've got to push through the fat pad in order to get down to where the plantar fascia originates. So you need a lot of pressure. There are many different treatment options for plantar fasciitis, and again, we haven't got time to go through all of those, but you can see those there on the slide. Realistically, the sensible thing to do is to start with mechanical treatment, so stretching exercises, good shoes, avoid walking barefoot, possible use of orthotics, and then moving on, if that fails, more towards injection therapy or to treatments such as shockwave therapy. What I tend to do, certainly on a private basis, I'd much prefer to do shockwave therapy before injection therapy. And when we are then going to consider injection therapy, my preference is to use platelet-rich plasma or to do cortisone injections under anaesthetic block, where we combine it with dry needling. And finally, we're going to talk about Achilles tendinopathy. Again, a relatively common problem. Relatively straightforward to diagnose. This is really by observation. You just look and you can see that the tendon is thickened. Palpation, you're looking for areas where the tendon feels more thickened and obviously painful. It's important to assess the range of movement and the strength. to do the squeeze test if you suspect that you've got a ruptured tendon. And then imaging techniques are extremely helpful in determining the level of pathology and also the location of the pathology. For the majority of people, when they're going to get Achilles tendinopathy, it usually occurs in this section of the tendon. However, there is a smaller group of patients who will get the pathology at the insertion of the tendon, and this generally is a harder treatment or harder condition to treat. It's far less responsive to physiotherapy. There are many intrinsic risk factors for Achilles tendinopathy and also extrinsic risk factors, and it's important to consider those. In terms of treatment, well, really trying to separate between insertional and non-insertional treatment. Eccentric heavy load exercise is the mainstay of treatment through physiotherapy, and this is primarily beneficial for non-insertional, so mid-substance tendinopathy. It's far less effective for insertional pathology. Injection therapy, again, it's more beneficial for non-insertional, and the two injection techniques that I like to use are either a high volume injection, which is administered under ultrasound, or again platelet-rich plasma injection, which is showing very promising results. Shockwave therapy, again, can be useful for both. Equally, probably better for insertional than non-insertional Achilles tendinopathy. Footwear and orthoses are relatively straightforward. Obviously, again, it's avoiding walking barefoot, to use a shoe with a small heel raise, generally that's supported. Orthoses are probably more beneficial for insertional Achilles tendinopathy because the pain occurs at the insertion and is often associated with friction against the back of the shoe. So if the heel moves too much in the back of the shoe because of a structural anomaly, then the pain is likely to be greater. So using an orthotic can help. And then finally, surgery. I do far less surgery now than I used to for Achilles tendon disorders, primarily because of the advances that we've had through injection therapy and in particular shockwave therapy. However, it has its place if the above measures fail. Thank you very much.